Good morning, everybody. Today, it is my pleasure to welcome you all to the morning webinar hosted by Amrita Alumni Association and in association with the Department of Clinical Haematology and Bone Marrow Transplant. So today we have a very eminent speaker who is alumni of the first batch of MBBS trainees at Amrita. She's known to all of us. She doesn't need a particular introduction, but it is my pleasure to introduce Dr. Anusree Prabhakaran, who is an alumni of 2002 batch, and she is she did her DM in clinical hematology from PGI Chandigarh, and then now is a senior consultant at Deenanath Mangeshkar Hospital and Research Center at Pune. So today she's going to speak to us about a very important topic. We all know that myeloma is one of the most common hematological cancers. And earlier, when if I go back in time and then start looking at how myeloma therapy was started initially, when I was doing my MBBS, it was VAD, vincristine, adriamycin, and dexamethasone. So, and the longevity was much less than what we see today. And most of them would have hair loss, vomiting, extravasation, all sort of problems used to happen. It's a totally different scenario right now when we have immunomodulators, we have proteasome inhibitors, and whatnot. So that we are able to treat myeloma more like hypertension or diabetes in many of the patients, not for everybody, at least many of the patients have a good long quality of life with myeloma. So in this background, we have to get ourselves updated on the newer modalities of treatment, particularly targeting the immune system. So Dr. Anusree is going to talk to us on this topic on immunotherapy in myeloma. With these words, I would like to hand over to Dr. Anusree.
Okay, good morning to all of you. Thank Dr. Neeraj for those kind words. Pranams at lotus feet of Amma. So as said before, myeloma has been interesting various departments starting from ortho, nephro, hematology. If you see the treatment timeline for myeloma from 1960s till date, we can see that from 1980s onwards, some mode of immunotherapy has been we have been using in the form of allogenic transplant or immunomodulatory drugs like thalidomide, lenalidomide, pomalidomide, and from 2010 onwards, monoclonal antibodies. Okay. So for today's discussion, I have chosen immunotherapy because I feel that with so much advancements happening, maybe 5-10 years down the line, this may be the standard of care. As it's a new area, it is learning for all of us. And third, there is a selfish motive too. One of these drugs is coming as a trial to our hospital, so I thought I will add that too to the talk. Okay, so immunotherapy in myeloma could be in the form of CAR T cells, monoclonal antibodies, antibody drug conjugate, bispecific T cell engagers or bispecific antibodies, checkpoint inhibitors, and CAR natural killer cells. So for today's discussion, we will concentrate on 3 of them: CAR T cells, antibody drug conjugate, and bispecific T cell engagers or antibodies. What are the other examples of immunotherapy? It could be like oncolytic viruses, cancer vaccines, and various cytokines. If the immune system has to recognize a malignant cell, the target cell, as abnormal, it has to locate a particular antigen. So what could be that targetable antigen on a plasma cell? There are various candidates: SLAM F7, BCMA, transmembrane activator, calcium modulator, and cyclophilin ligand interactor, CD38, CD19, G protein coupled receptor class 5D, and FC receptor homologue 5. So out of these, we will discuss about BCMA and how to target it. If we see various surface marker expression from stem cell to plasma cell, we can see that BCMA expression, CD269 expression starts from late memory B cell. So BCMA is a B cell maturity antigen, which is present on cell surface of late B cells, plasmablasts, and plasma cells. And it is considered as a perfect target for antibody drug conjugate, BiTE therapy, and CAR T cell therapy. This is a cartoon to show the plasma cell with cell membrane with expression of BCMA with its ligand BAF and APRIL. And once these ligand binds to BCMA, then NF-kappa B pathway gets activated. And how does it work? In normal physiological conditions, when the pathway gets activated, it supports the survival of plasma cells. It helps in production of antibodies and class switch of immunoglobulins. In multiple myeloma patient cells, it promotes the proliferation and survival of myeloma cells, and it helps to maintain an immunosuppressive microenvironment in the marrow. And increased soluble BCMA level has been shown to be associated with disease progression and poorer outcome. So if you see this cartoon, this gamma secretase enzyme cuts off the part of BCMA and releases into the circulation. There are two implications for that. If you see increased level of soluble BCMA in the blood, that means there is increased tumor load. Second point is that then these immunotherapies won't be able to work because BCMA is not available on surface to be attached onto. So BCMA-based immunotherapies are in the form of CAR T cells, antibody drug conjugate, BCMA NK T cells, and BiTE. So what is the need for all these therapy? What is available to us at the moment? We all rely on steroids, proteasome inhibitors, immunomodulatory drugs, and now daratumumab. So what happens to people who are refractory to CD38 antibody? This is Mammoth trial. 275 patients from 14 academic centers. If you see, if a person is penta-refractory, that means refractory to DARA, 2 proteasome inhibitors, and 2 immunomodulatory drugs like len and pomalidomide, then their median survival is only 5.6 months, or as high as 11 months if not triple refractory. And if receive some kind of treatment, then overall response rate is only 31%. Progression-free survival of 3.4 months. So can we improve upon it with this immunotherapy? That is the discussion for today. So these 3 immunotherapies, how do they work? So the antibody drug conjugate, this is the cartoon to represent that. This is the antibody with a drug attached to it, and it binds to the BCMA and releases the drug into the cytoplasm of the plasma cell. And that particular drug will cause the plasma cell death. If we come to CAR T cell, this is the T cell. And with the help of a viral vector, this T cell is engineered to express this chimeric antigen receptor. That receptor is able to bind to BCMA, and it produces cytotoxic cytokines and causes myeloma cell death. And how does bispecific antibodies work? This is the construct, how it looks like. And it has an FAB fragment which can bind to CD3, and other fragment will bind to BCMA. So the T cell will come in proximity to the myeloma cell, and it will cause myeloma cell death. It may be in the form of a T cell engager or an antibody. The antibody has an FC fragment. We'll come to it later. So the first thing we will discuss is antibody drug conjugate. See the structure. This is the antibody, and this is the drug, and there is a linker protein. So this is the antibody, which is an humanized BCMA IgG1 monoclonal antibody. This is the drug, the cytotoxin, which is a microtubule disrupting cytotoxic agent, monomethyl orostatin F. And there is a linker to attach the drug to the antibody, which is a protease resistant linker. So the belantamab mafodotin will bind to the BCMA. Then it gets internalized and the antibody undergoes disintegration. And with the help of cathepsin, the drug gets released into the cytoplasm. Then the drug will disrupt the microtubular network of the plasma cell, and it can result in apoptosis or antibody-dependent cellular cytotoxicity or antibody-dependent phagocytosis. So belantamab mafodotin, one of the first trials was DREAM2 trial, which is an open label randomized phase 2 trial, which included relapsed refractory myeloma patients who were refractory to PI, IMiD, and anti-CD38. 196 patients were there. They were stratified as 1:1 randomization to more than 4 lines of therapy or less than or equal to 4 lines of therapy. And there were 2 drug categories. One was belantamab mafodotin at 2.5 mg per kg once in 3 weeks IV, or 3.4 mg per kg once in 3 weeks IV. So the endpoint was progressive disease versus unacceptable toxicity. So we will look at the 2.5 mg per kg cohort. So the median age was 65. Most of the patients had, from the time to the enrollment in the trial was like 5 years. High-risk cytogenetics was seen in around 40% patients. And more than 4 lines, majority of them were more than 4 lines of therapy, 80%, and all were DARA failures. And if we see the results, out of 97% patients, around 31 patients had some kind of response that amounted to 32% overall response rate. And median duration of response was 11 months. Just modest response. And the main side effect noted was keratopathy, which was seen in 70% individuals. And out of that 70%, 44% it was asymptomatic. 3 had to discontinue the drug. It was time limited, and if we reduce the dose, most of them were able to continue with the drug. And even if somebody had a grade 3 or 4 ophthalmic toxicity, 84% of them vision could be returned to baseline. So while using belantamab, it is imperative to have an ophthalmologist in the treating team. If there is a significant corneal injury, how to handle it? If it is grade 1, you can continue. Grade 2 and 3, one has to wait for improvement and then reduce the dose and resume. If it is grade 4, one will have to permanently discontinue. So what happens if there is a dose delay? Out of 97, 16 had dose delay. Out of them, 12% had frank progressive disease. And if we see the 2 treatment cohorts, 2.5 mg per kg and 3.4 mg per kg, if you see overall response rate, duration of response, PFS and OS, everything, 3.4 milligram performed poorly. So it was decided to continue with 2.5 mg per kg. And it was shown that belantamab has acceptable safety profile at this dose of 2.5 mg per kg IV once in 3 weeks. So this drug got its FDA approval for use in more than or equal to relapsed refractory myeloma patients who have had more than or equal to 4 lines of therapy at the end of DREAM2 trial. After that, there have been series of DREAM trials. DREAM3 was belantamab versus pomdexa. It is still enrolling. DREAM4 was is belantamab with pembrolizumab, 2 immunotherapy agents. It is also still enrolling. And DREAM5 is quite interesting. That is belantamab with different other molecules versus belantamab monotherapy. If we see the different drugs which were combined with belantamab. One of them you can see is gamma secretase inhibitor. We found that gamma secretase enzyme is the one which is involved in tearing off BCMA from its self surface and increasing the blood component of soluble BCMA fraction. So if you can inhibit that, then the available BCMA will be more, and BCMA-based immunotherapy can work better. It can augment the result. So this trial is expected to complete in Feb 2028. And just to give how it is going to be, if preliminary result, belantamab 2.5 mg per kg and feladilimab, which is a T-cell co-stimulatory molecule, the overall response rate, which was like 30% with belantamab alone, could be improved to 67% when combined with feladilimab. And these are like expected combinations from DREAM6 onwards: belantamab with lendexa and bortidexa. And DREAM6 is also an extensive study which is expected to get completed in next month. And if we see this belantamab with borti and dexa combination, you can see that overall response rate, which was like 30%, could be improved to 78% in people who were otherwise refractory to proteasome inhibitor. Main side effects were thrombocytopenia and keratopathy. And if we combine with pomdexa, this is not part of DREAM trial. This is a separate phase 1 trial. You can see that in relapsed refractory myeloma patient, overall response rate could be improved to 95%. There are various other DREAM trials. Out of them, DREAM9 is in newly diagnosed myeloma, where belantamab was combined with standard of care. And if you see the preliminary results in DREAM9 trial, you can see that people who have had VGPR, CR, or stringent CR with a lower dose of belantamab once in 3 weeks or 4 weeks is to the tune of 100%. DREAM14 trial is what we are part of in Deenanath Mangeshkar Hospital. We have already enrolled 4 patients in that. Drug administration has not been started yet. So that was the first part of the talk. Second one is about bispecific antibodies. So how does bispecific antibodies look like? So they have this construct with an Fc fragment and 2 FAB parts. One will bind to BCMA, other to CD3. And it is called a BiTE when there is only 2 FAB fragments. And it is called bivalent bispecific antibody when there are 2 FAB fragments, and trivalent if there are 3 FAB binding sites. So 2 types, only FABs and linker, and FAB with FC. What does this FC portion do? It stabilizes the molecule, extending its half-life, and it helps in antibody-dependent cellular type cytotoxicity and phagocytosis. I would like you to remember 2 molecules out of this. One is teclistamab, Majestic trial, where target was BCMA again. Weekly subcutaneous dose of teclistamab was used, and overall response rate was 65%. And elranatamab, Magnetis MM1 trial, where subcutaneous weekly dose of elranatamab has shown a 70% overall response rate. This was published in June 2022 in EGM, where teclistamab was used in relapsed refractory myeloma patients, triple class failure patients. Initially, smaller dose was administered to see whether the patients are able to tolerate the drug. Thereafter, actual intended dose of 1.5 mg per kg was given subcutaneously, and primary endpoint was overall response rate. And out of 165 patients enrolled with a 14 months follow-up, overall response rate was 65%, and out of them, 40% had CR. You had seen that with the belantamab mafodotin, overall response rate as a single agent was only 31%, and CR numbers were very less. And out of the CR patients, 46% are MRD negative, And the duration of response is like 18 months and progression-free time is 11 months versus with belamaf, it was, I think, around 2.8 months. There is a risk of cytokine release syndrome up to the tune of 70%, and neutropenia is also quite profound. The side effects are hematologic as expected, and some dyselectrolytemia and CRS, but grade 3 and 4 CRS is less than 10%. And neurotoxicity is less with bispecific antibodies, and grade 3 and 4 are around 1% only. And the second molecule, elranatamab, this is by Pfizer. It's a phase 2 trial with the intended dose of 76 milligram. Overall response rate of 70%, out of them CR is 30%, definitely better than antibody drug conjugate. And in 3 weeks time, you can see some response. And at 6 months, most of the patients would maintain that response. So what could be the future strategies with bispecific antibodies? One can combine 2 immunotherapies, teclistamab with subcutaneous daratumumab in relapsed refractory myeloma patients, dara at 1,800 milligrams subcutaneous. Overall response rate is like 70 to 100%. And at 66 months time, 93% of the patients were continuing the drug. And these patients were, out of them, around 70% had prior exposure to dara, and 20% had prior exposure to anti-BCMA targeted therapy. In spite of that, combining the drug gave decent results. And if somebody had a prior exposure to a BCMA targeted therapy, then one can use non-BCMA target like talquetamab, which is a G protein coupled receptor class 5D antibody, bispecific antibody, and cevostamab, which is an FCR receptor homolog 5 antibody. Around 20% in both the trials had exposure to prior BCMA therapy, and they had 50% response. Janssen has announced the talquetamab is a Janssen product, and it has got its US FDA breakthrough therapy designation recently in June 2022. So this was a phase 1 trial, first in human trial. It started in 2017 and expected to get completed by March 2025. 2 dosing groups, 405 and 800, and overall response rate of 70% and 64%. So we completed 2 parts. One is antibody drug conjugate. We discussed that it is belantamab mafodotin, and it is given as 2.5 mg per kg once in 3 weeks as IV dosing. And as a single agent, it gives an overall response rate of around 30%. And when combined with bortezomib, or lendexa, or bomdexa, overall response rate could be increased to up to 70%. And in DREAM9 trial, it is used in newly diagnosed patients with VRD, and overall response rate, patients achieving VGPR or better results is 100%. And the second discussion was about bispecific antibodies. So 2 molecules, teclistamab and elranatamab. And there are non-BCMA drugs as well, like talquetamab and cevostamab. So the final part of discussion is about CAR T-cell therapy. We get goosebumps seeing the result of, this is not in myeloma, this is in relapsed refractory ALL. If you look at Emily Whitehead, who had a relapsed refractory TB-ALL, who was the first candidate to receive CAR T-cell therapy in 2012. Now she is now 10 years down the line. So she had a tough course with CRS, ICU stay, hypotension, and organ failures, and see how immunotherapy can change the life of a person. So same thing is coming up in myeloma. The T cells are engineered to produce chimeric antigen receptor. So let us look at the structure of a chimeric antigen receptor. So this is the antigen binding domain, which is made of single chain variable fragment. It has got a spacer to have sufficient length so that it can bind to the target antigen on the cancer cell. There is a transmembrane part. There's a co-stimulatory domain, which is CD28 or 41BB. And there's a CD3 T cell signaling domain. So how is this machinery introduced into the cell? First, one has to make a genetic sequence for the expression of this particular receptor. And a virus is used to introduce this genetic material into the human T cell. Lentivirus is usually what is used by transduction or transfection. And the binding domain, that is the antibody part, could be either human or mouse. And the transmembrane domain is made of CD8 or CD28. And co-stimulatory domain is either CD28 or 41BB. And activation domain is CD3. So there are different generations of CAR based on how is their structure. First generation had only the antigen binding domain, transmembrane domain, and CD3. Second generation has a co-stimulatory domain with 28 or 41BB moieties. It helps in optimal T cell function and T cell proliferation. Third generation has two co-stimulatory domains. And fourth generation is called not a CAR, it's a truck or armored CAR, which is capable of producing cytokines, enzymes, production of suicide genes, etc. So T cell dysfunction or T cell exhaustion could be overcome with these trucks. So what is the process as such? So the patient first undergoes leukapheresis. So in the white cells collected, the T cells are isolated. Then these T cells are engineered so that they will express the chimeric antigen receptor. So the gene is introduced with the help of a viral vector. This could be done with two techniques, either by a Clinimax Prodigy machine or with a GMP facility where everything will be done manually. And at the end of it, the CAR T cells are produced, then they are expanded. Thereafter, the patient is given a lymphodepleting therapy with fludarabine and cyclophosphamide, 30 milligram per meter square and 300 milligram per meter square for 3 days. Thereafter, there is CAR T cells are infused. Then they start working. Once you infuse, there could be acute phase reactions or late phase reactions in the form of cytokine release, neurotoxicity, cytopenia, B-cell aplasia, infections, and some long-term side effects. Everyone should know about CRS. It may be grade 1 where there's only fever, grade 2 where there is hypotension which is requiring only hydration and or low flow nasal oxygen. Grade 3 when there are vasopressors required and high flow nasal cannula or a venti mask. And grade 4 when there is multiple vasopressors are needed and patient requires an invasive ventilation. And neurotoxicity maybe in the form of drowsiness, seizures, focal neurological deficits, or raised ICP. There's various grading for that. And these toxicity is because of very high levels of interleukin-6 and neurotoxicity. Primary cytokine involved is GM, CSF. How do we manage? CRS, tocilizumab, and IL-6 antibody. And in neurotoxicity, steroids, dexamethasone is used. So there are 2 FDA-approved CAR T cells now, edacaptogene viclucel and ciltacabtagene autoleucel. This is how edacaptogene viclucel looked like. So this was based on phase 2 KARMA trial, where this drug got its product got its approval. This is idacaptogen CAR design, where there is a one antigen tumor binding domain. So KARMA trial was in patients of relapsed refractory myeloma who had more than or equal to 3 prior regimens and DARA failure patients. 158 were screened, 140 had leukapheresis, and total 128 patients received the drug, the product. Majority of them had 450 million CAR T cell infusion, and the follow-up varied from 1 to 1.5 years. Primary endpoint was overall response rate, and around 35% had baseline high-risk cytogenetics. So if we look at the, categorize them into 150 million cells, 300 cells, and 450 cells, you can see that the best result was obtained in the people who received 450 million cells, overall response rate of 82%. And first response was achieved in a month's time, and time to CR was nearly 3 months. Median follow-up of 3.3 months, and MRD negative in all the patients by 26%. And out of patients who had CR, around 80% had MRD negative status. Whatever may be the prior line of therapy received, if combined with, if given CAR T cell therapy, it can make the progression-free survival equal. And overall survival at 12 months, 80%, and at 24 months, 50%. If we give a higher T cell dose, then they have better progression-free survival. If you see this curve. And if a deeper response could be achieved in the form of CR or a stringent CR, they have a better overall survival. Main side effects, neutropenia and anemia and CRS. That was about idacaptogen. And now ciltacabtagene. This was CARTITUDE trial, where in this product, there are 2 BCMA binding domains. That is the difference in the CAR T cell structure. So single arm open label phase 1b2 trial in people who had more than 3 lines failure. 113 patients were enrolled. 101 had lymphodepletion. Ultimately, 97 received the infusion. Here, the target dose planned was slightly less than 1 log less than that in KARMA trial. So the median dose administered was 0.7 into 10 to the power 6 T cells per kg. The other one we had told the absolute number. So overall response rate was the primary endpoint. High-risk cytogenetics was like 23%. In the previous one, it was like 35%. So what was the result? Much better. Overall response rate was like 97.9%. Out of that, stringent CR was like 82.5%. And stringent CR deepened over time, and 83% at 2-year follow-up. First response in 1 month's time, best response by 2.5 months, and duration of response is not reached. Progression-free survival, if you see, at 2 years, 64%, and overall survival at 2 years is 70% versus 50%, what was seen in idacaptagene. CARTITUDE trial, for the sake of time, I will not be discussing this part. So if we compare idacaptagene versus ciltacabtagene, in idacaptagene, 450 million cells were used. Here, 0.75 per kg million cells. Median age was the same. Prior lines, around 6 lines people had received. Penta refractory was 26% here and 42% here. High-risk cytogenetics and extramedullary disease was much more in idacaptagene arm compared to ciltacabtagene arm. And CRS was, in spite of having smaller number of T cells infused, CRS was more common in ciltacabtagene arm. Infections were slightly on the higher side in idacaptagene arm. Delayed neurotoxicity was reported only in cilta group. Efficacy was significantly different. Overall response rate 73% versus 97%. Stringent CR 33% versus 78%. Progression-free survival 9 months versus 24 months. Median duration of response 11 months versus 22 months. There are various other CAR T cell products. We discussed only Cartitude and Karma. There are so many others as well, including Legend and Evolve. But there could be some problems with anti-BCMA molecules as well because of antigen escape, where the cells stop expressing BCMA, or there are BCMA expressed on normal cells which are subject to side effects because of cell death. Okay, what could be the long-term problems? This is a very recent paper which showed that the rate of subsequent malignancies in patients who had modified immune effector cell infusion is nearly same as that of controlled population. That means it's a safe product to use even when you think of long-term. So many things coming up, like bispecific CAR with CD19 and CD38 combination, CAR NK cells as well. So if we compare all of them, antibody drug conjugate is like a drug. It's an off-shelf product. You can just take and infuse. There is no delay in time, but it's a continuous therapy. You can't stop it. You have to continue till the patient responds. Bispecific antibodies are also like that, off-the-shelf product, continuous therapy. So you are looking at significant cost. But CAR T cell is only single time, but there is a long production time. So what could be the potential change in myeloma treatment with these immunotherapies? High risk may be converted to standard risk. There could be more MRD negative patients and potential cure. Chemotherapy-free regimens may come up in future as the only therapy. And possibly we may have to change the diagnostic test and follow-up tests so that you can identify the targetable antigen from the beginning. I feel future is exciting and bright for myeloma. So we discussed three things: antibody drug conjugate, belantamab, bispecific antibody teclistamab and elranatamab, and CAR T cell therapy, idacaptogene and ciltacabtagene. So there are some consensus guidelines. We'll not be discussing that. So thank you. That's all from my side.
Thank you, Anu, for the fantastic lecture. You have a knack of teaching. So, you've taken us through such a complex, novel treatments in myeloma, and really given us an overview of the three emerging therapies in myeloma. We are also looking forward for the enrolling patients into the DREAM14 trial, the new molecule. But of course, the problem is the hepatotoxicity. And I will open this session for questions. We have 5-10 minutes for discussion. Let me start with one comment. And do you think of the three therapies that you have discussed, any one particular therapy is likely to emerge as the front runner in 5 to 10 years from now?
What I am impressed about is about bispecific antibodies. It appears that it is easy to administer. It appears that it does not have a delay time. It appears that as they are subcutaneous and can be combined with daratumumab, and you don't have to depend upon any machinery for it. I think I'm more keen on that second category of drugs, bispecific antibodies and T-cell engagers.
I was quite impressed with the data that you showed with the CAR T cells, especially nullifying, except for the cost. And I think in CAR T cells, it kind of nullified how many therapies that you had received. It didn't really matter, right? That's what.
Yes, that was what was seen.
And so it doesn't really matter whether you are a high risk or a non-high risk or whatever. So some people just respond to that very well within a single infusion. So what if in the next few years, people work on the toxicities, the escape mechanisms, and T cell fatiguing. I mean, all those things are sorted out, and the cost comes down. Uh, because recently we were actually reading an article from 2000 where they were talking about the cost of Gleevec. So the Gleevec was priced so high that people never thought the Gleevec would be popular. So is that something which we would be looking at? Isn't it the most potent therapy?
I would say very, very convenient therapy, and because you might be knowing about Immunoact already. So I don't know whether you are part of their ALL and lymphoma.
Yeah. So yes, we are aware. So in India now, Immunoact is there, and then Immunile is there. The Biocon, and Dr. Reddy's is also coming up with CAR-T, right? So so maybe CAR-T will progress fast, I hope.
Actually, because of Dr. Malinkari, one of our patients actually received myeloma CAR-T. So
how was the experience?
Product was sent to Malaysia, and we received the product. It was infused on, I think, 29th of December for a person who had even received selinexor. So no, he failed. He passed away in 5 months' time. It didn't work. His M-band was increasing after 1 month of. One more ALL patient we had, sir had used CAR-T, but he also did not respond. Maybe that is why my.
That is why you are biased, probably. Again. So I will open the session for questions. Postgraduates are here. Anybody wanting to ask a question, you have the opportunity to ask to Dr. Anu right now.
I'm not an expert in immunotherapy. I also read like.
I was also the PG Madam is here. Thanks to PG Madam for organizing this wonderful session for us. I was actually telling PG Madam that we should request Anu to be our adjunct faculty, so that so that our students benefit from your teaching skills.
I like teaching, yes.
Yeah, we will do that, sir. We'll do. Definitely we'll do.
There are no questions. Okay, if there are no questions, I will hand it over to PG Madam. And thank you very much, Anu, for the very enlightening session. It was really a lot of learning for all of us today. Thanks for taking so much time. Yeah. I really I know how much time should have taken for this preparation of this talk. No? Very, very well done. Thank you so much.
Yeah. Thank you. Thank you very much, Anu. Can you hear me?
Yes, ma'am.
Can you hear me?
Yeah. Yes, I can.
Thank you so much, Anu. Yeah, you took me really 22 years back when I was teaching you. It was slow and steady. I used to ask everyone, did you understand? So that type of teaching you still follow. Very slow, and it was very understandable. I am not an oncologist, but then I understood it so well. Thanks to you, Anu. And I wish you all the best. You prosper, and I will definitely take action to add you as the guest lecture forever, all the time. And we always will look forward to your cooperation in this. You are happy with it, Anu?
Yes, of course.
You
These
agree with
topics, it is like learning for us also. No? Then only we will revise and get updated.
Exactly. Yeah. So I will definitely put a request to our medical director, Dr. Prem sir, for adding you as a permanent guest faculty for Dr. Sidharth sir department. Okay, Hannah? That's fine. In his department, you are fitting actually. So that's fine. Actually, you.
No has to answer. We have already put in the request, ma'am.
Okay, fine. So my second request will be supporting her. Okay, because physiology department was asking to add her, but then I think she fits more in clinical with you. That is her subject. So I feel very happy about it. Thank you so much, Anu. Please convey my regards to your husband and hugs to your son.
Sure, ma'am.
Okay, thank you so much. Thank you. Thank you, Dr. Sidharth, and all your students who has attended today's session. Thank you very much for audio video, who has been always very helpful to us. And this will come in YouTube. So for those people who could not attend today because of their duty or whatever, they can see that YouTube connection in this. This topic will come as such. It will be there. Maybe a little editing may be there. Unwanted sounds will be edited. Otherwise, it will be as such. Dr. Sidharth, sir, you agree for it?
Yeah, sure, man. I think it will be very good.
Thank you so much, Dr. Anu, Dr. Sidharth, and all the PGs, attendees, and delegates. Thank you, sir.
Thank you. Anu.
Thank you.
Thank you.